Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is infective non-union, a very complicated, very dangerous and challenging cases for all orthopedic surgeons. How we can manage this type of infective non-union. It is very difficult to manage, but there is a solution. That is the magical solution, and we call it Ilizarov. So our topic is infective non-union treated by Ilizarov. And our speaker is the one and only, the pioneer Ilizarov surgeon in Bangladesh, Professor Mofakkarul Bari sir. I would like to request Professor Mofakkarul Bari sir to our show, OSA, Orthopedic Solution Academy.
Thank you very much for inviting me for joining in your program today. Okay, thank you, Tanvir, again.
Thank you, sir. Thank you very much. Dear viewers, we have two learned academic experts with us. One of is the very prestigious Professor Abdul Ghani Molla sir, the director of NITOR and the president of Bangladesh Orthopedic Society, as well as the secretary of ASAMI. And another one is very enthusiastic, dynamic Ilizarov surgeon from Patna, India, the joint secretary of ASAMI India, Dr. Shamsul Huda sir. I would like to request Dr. Shamsul Huda sir to join with us in our program.
Thank you, Dr. Zanvi. Thanks a lot.
You're most welcome. Dear viewers, I don't want to spend any more time as because of we all are eagerly waiting for our presentation. Now I'd like to request Professor Mofakkarul Bari sir to start his magnificent presentation. Professor Mofakkarul Bari sir, and the topic is infective non-union treated by Ilizarov.
Now, visible? Full screen?
Yes, sir. Yes, sir. We can see your screen clearly and we can hear you loudly. It's fantastic.
Okay, thank you so much. So, dear friends, especially Tanvir and Shamsuluddha from India, and dear viewers, those who are listening to us, and today we are going to talk on the infected big gap non-unions of the femur and tibia. Before that, I have talked on osteomyelitis, and in the same sitting, I talked on the infected non-union of the femur and tibia and other bones and the forearms. And this is, I always love to show my institutes, different institutes where I got training. And this is the Kurgan Ilizarov Center, orthopedic capital of the world. This is our National Institute in Dhaka, 1,000-bedded trauma and orthopedic center. And this is my current hospitals, that is in Bari and BIHS. And this is my center. This is Kurgan. This is Ilizarov. 4M, man, meat, method, and magician. So learning Ilizarov is like learning a language. That means teach alphabets, grammar, improve your vocabulary, and use it. Nobody can teach you how to write a short story, a novel, or a poem. Read biomechanics. This is very important. And biomechanics of the Ilizarov is very, very important. And at the same time, you should have to learn the safe corridor and the biology of the human body. And you should have to know the uses and variations, various permutations. And so we have so many ways to build a cat based on experience and concepts, like one's language is different from others. So you can find it. This is my definition that I have created this one in 2006, thinking about the varieties of definitions of the non-union. And arrest of bony fracture repair process, the formation of fibers of cartilage tissue in between the main fragments, and fracture has remained uninvited for 6 months to 9 months due to mechanical or biological failure, just by clinical and radiological. If you think about this definition, you can find everything clinically, biologically, and radiologically evidence what is non-union. So Ilizarov treatment strategy, if you think about the stiff non-union, you should have to go for heel that needs adequate stability and good alignment. And hypertrophic non-union we are getting most of the time, and at the same time we are getting atrophic non-union also and lax non-union. This is also, think about this hypertrophic non-union. This is usually due to mechanical failure due to instability. Radiograph shows florid callus. There is excellent blood supply, only you cannot find mechanical stability. Therefore, there is no need to reseed the bone ends, and bone grafting is usually unnecessary. And Ilizarov surgery, you don't need to do that. Ready to heal needs adequate stability, and you should have to have a good alignment. So this is management of the hypertrophic non-union, which was published in 2000. You can see here in 18 in Medcrave Journal. So this is how you can distract and you can get good union. Don't need to open up, and this is a callus formation. You can see the right side. Atrophic non-union is due to the biological failure, non-reactive, more or less avascular non-union. Radiologically, callus is absent, and the interpositioning tissue is usually loose fibrous tissue. These require bone grafting, electrical stimulation, in addition to restoring stability. In normal situation, you should have to go for bone grafting, but in Ilizarov surgery, you don't need to that. Lax non-union, infected non-union, this is we call the shaitan. Shaitan means you should have to remove the debridalized tissue and you should have to go for debridement. And this is the same again infected non-union. And what are the issues? What we can see in infected non-union? These are these things: bone loss, soft tissue loss, infection. You will find gap non-union. You are getting a scarring. Of course, most of the times with infection, you will get the deformity and shortening and bone muscle atrophy, and you will get the diffuse osteopenia. Patient will suffer psychological problems because you need to go for frequently multiple surgical interventions. The problems of INU, the problems in infected non-union, you'll get sinuses, you'll get osteomyelitis, bone and soft tissue loss, you'll get fibrosis, you are getting all the time osteopenia, of course, the skin problem, and adjacent joint stiffness, most of the time we find it, and complex deformities. And to treat the complex deformities with infection is very difficult. And of course, the ALLD and multi-drug resistant polybacterial infection. Look at this case, loss of big gap, big gap. This is the exception. Day one, you can see this is the case of very big. From day one, you can say this is going to be non-union. So not all the time, the 6 to 9 months, you can see this here at the right side, the exposed that bone, you can see the right side. And treating infected non-union is a challenging all the time for the orthopedic surgeons. Two skills of management, conventional method and Ilizarov management. Now you can see here 32 years old female, non-union of the right lower tibia with a broken plate. See the deformity? And she was treated elsewhere by plating and fibular grafting. If you look at this one, this is the conventional method. And as a result, what happened? The plate was broken, the graft was not properly placed, and it was broken. And the patient came to my place. I treated this, remove everything. You can see trifocal. This is trifocal bone transportation. See here, put a guideline, a guide wire, intermedullary, and gradual transportation. This is right side. You can see after 1 month follow-up, and this is after 1 year. You can see here, same girl, same lady, treating with last year during the corona period. And this is the radiographic view after 1 year. You can see hinges for correcting the deformity. These are the hinges, placement of the hinges. And this is, you can see, before treatment, look at the X-ray, and this double plating was done, fibula grafting was here, and failed case. So after 1 year and 2 months, this is the follow-up. So we achieved union, we achieved the infection, we have control, union, and at the same time, LLD was corrected, and deformity was also corrected. So what to do? Gap non-union, bad case. The more difficult the case, the more is the Ilizarov. Ilizarov keep you always safe. Plan to realign, and pre-operative planning is very important. The power of planning is very, very important before going to start the surgery. Dear friend, look at these, 27 centimeter. The bone was fall down in the ground, and the boy came to my place after 3 days with that bone and told me, doctor, I want to keep my leg like this, you just put inside and do my surgery. I was laughing at that time, and my aim was how to cover a long defect which is more than 10 centimeter in tibia because of infection and gap, tumor dissection, traumatic loss, which is very difficult to treat by conventional method. That's why we have treated more than 10 centimeter defect by tibialization in the tibia of fibula with Ilizarov technique. Management of Ilizarov fixator, you can see here, I told you all the time, INU, infection, gap, deformity, and shortening. 4 very difficult things. And Ilizarov can solve all these things simultaneously. You can go for radical debridement. You should have to go for bone transport, and you can do it acute shortening, and then you can go for lengthening. So what are the strategies? 2-stage treatment, you can go for that. Stage 1, infection eliminations, radical debridement of necrotic and infected tissue, and you should have to prescribe the antibiotics, or you can go for cements. Stage 2, reconstruction of bone and soft tissue, you can go for flaps, autogenous bone graft, or cancellous bone grafting, you can do that, cortical bone grafting, and vascularized bone grafting. So when we can open the non-union, and when to open? To reshape the bone ends for intrinsic stability, and to remove something out and to something in, that is bone grafting. And in reserve surgery, you don't need to do that. And most of the surgeons sometimes they go for bone grafting. And in reserve surgery, we have 3 modalities of treatment: monofocal treatment, bifocal treatment, and trifocal treatment. Fibula is readily available with length reaching up to 30 centimeter. It is a strong cortical bone, straight and designed to withstand weight-bearing forces. You can see here, most of the reserve surgeons, they know how to do that. Fibula, you go for osteotoma in the proximal part, then you can transport that one, you can put it in the tibia. Then monofocal treatment for stiff non-union, type 1 stiff non-union with deformity, sclerotic bone graft ends and shortening, and at the same time angulation less than 7 degree, and angulation here is greater than 7 degree. So surgical technique based on few basic principles. Before doing that, you can go for biopsy culture. All necrotic and non-bleeding bone must undergo debridement. A high-speed bar is used to debride the bone, and continuous cooling irrigation is applied to the bar to decrease the thermal injury. The tibial cortex experiences very little bleeding. We must look for the paprika sign. And all patients are treated with within 6 weeks antibiotics that are specific to culture organism. This is the strategies of infected non-union. If you think about the location of the bones, femur and tibia, measurement of the bone loss, greater than 5 centimeter, less than 5 centimeter, you can go for dissection and bone transport. Same case, the tibia that I told you earlier. If it is greater than 10 centimeter, or you can go for resection, Ilizarov double level bone transport. And corticotomy, most of the Ilizarov surgeons, they know what is corticotomy, low energy osteotomy, with the preservation of periosteum, endosteum, and the bone marrow. And so here you can see the monofocal bone transport corticotomy, one level. This is bifocal from upper part and from the below part, from the below. And let us see some case illustrations. I would like to share my experience that I showed you earlier. 70 years old boy, post-traumatic right gap non-union of the femur. That means day one, I told you, after 3 days, he came to me, look at this red mark. This is the whole big femur. So what to do? He was in another place. They advised him to go for amputation. And here, lower part of the pilot fracture and lower tibia. You can see here in the ipsilateral. So, young chap, look at the face. Look at the face. It is open. No femur here. 17 years old boy. Now, then look what I have done. Next year with Ilizarov, telescopic rod, and then here in tibia, the same sitting. I have corrected the tibia, the same sitting. Look, and this is the big gap with oblique arch support, with here arch. And then look at this here. I have done the corticotomy here in the upper femur subtrochanteric corticotomy, and then this is going for lengthening. You can see here gradual lengthening, and there was a periosteum in the distal part. And I was just observing what is happening there. And then see, this is all the lengthening part. This is the lower part of the femur. A patient is walking in my center. You can see walking in the center, and tibia is already corrected. I have removed the apparatus. This is after the 6 months follow-up, and he's under my observation. And I have done the 3 days back. I have done the corticotomy here, distal part of the femur. That was a massacre here. I waited for healing of this. Now I'll go for transportation from the lower part. And this is a very thin part of the bone. So it will come up, then I'll see what is going to be happen. Now patient is happy. See, ipsilateral, very dangerous, big gap, trauma in the femur and the lower tibia. This is a 40 years old lady. You can see treated elsewhere with uniaxial fixator, came to my place, big gap, tibia, and comminuted lower end of the femur. Infection, open wound. You can see the skin condition is not good. You cannot go for bone grafting here. You cannot go for plating here inside. All interlocking lane here. Bone quality is not good. Now, only the option is very good option is Ilizarov. Keeping the uniaxial fixator in situ, I will start doing the application of Ilizarov. Now you can see, dear friends, here I have already overcome this one femur, and I have transported the tibialization of the fibula. See here in the distal part. And now you can see during treatment sequential x-rays, and this is the lady, and this is, you can see from here to here, from here to here, this is coming. Now clinical appearance of the patient. You can see she's happy. If you look at this is a little bit, you can see in the x-ray, this is the, maybe if you look at the x-ray, it looks like a thin. No, this is stable. Now it's going to be massive. This is the clinical appearance of the patient. So this is the case, again, 40 years of comminuted, infected, you can see, treated elsewhere, came to my place. They suggested for going for amputation. Then you can see here, then what I have done during the treatment. You can see here, no bone, gap, only distally you can see. Sequentially, we are treating the patient with proper dressing, and this is, I have put the Ilizarov apparatus, see the olive wires by internal transportation and by putting the guide wire. And then this is during treatment, and there are lots of, in between the cases, lots of pictures, but I could not show that. And this is sequential treatment, and this is finally from this. And tibialis anterior vessel was trochanteric crest, and pressure is surviving with the posterior tibial artery. And at the same time, 32 years old man, big gap non-union. I'm just showing the difficult cases, how to tackle with the Ilizarov apparatus. Look at this case. Look at these. Only the multiple K words or Ilizarov words. No shunts here in the tibia. I never use shunts in the tibia. In the proximal femur, I use shunts. Here you can see, if your gap is more than 5 centimeter, you can put a guide wire to maintain the axis. And this guide wire, K wire, helps you for irritation, increasing circulation. So this is during treatment, you can see, and you can see in the right side, right side, massive bone formation. This is trifocal bone lengthening, trifocal osteosynthesis by Ilizarov. And this is after removal. This is a big gap, gastro 3B, exposed bone, treated elsewhere with initial fixator. Then again, here, assessment, clinical appearance of the patient. Look at these, again infected, exposed plates. He was treated elsewhere, came to my place, he removed that one. Then I started doing, after application of Ilizarov, see the very big gap. You can see, after 5 months follow-up, and after removal, before going to remove the apparatus, you can see a good callus formation here going on, and the guide wire inside the medullary cavity. And this is after treatment. You can see the clinical appearance of the patient. It was before, and this is after good callus union and formation. So again, you can see comminuted, infected. Look at this, lower one third of the tibia with initial fixator in situ. Remove that one. Trifocal, you can see, proximal and distal. Then radiographs after 11 months, left tibia with a discharging sinus. Then I started, what I have done, this is the wire technique. This is the beauty of Ilizarov. You can see from the transverse and oblique side, I have put the console wires, just one cortex to another cortex, to control the infection of the tibia. And then I have achieved good, infection control. You can look the lower end of the tibia, discoloration, it was before. Now the change of the skin, redness of the skin, that is infection is controlled. Another 70 years old male, infection you can see, very big gap, uniaxial fixator, treated elsewhere, gastro 3B, 70 years old male. Considering the age of the patient, what will you do? You will suggest for amputation? No. He was the brother of a lady doctor, came to me, and what I have done, you can see, put the Ilizarov, again inside the very big gap, guide wire. It was treated in 2016 or 15, and then after 8 months follow-up, look at this. The infection was controlled, and good callus formation. After 2 years follow-up, you can see from that condition to this condition. So see how he is working. How he's working after 3 years follow-up. I told him to come to my place sometime so that I can keep the record. This is also 70 years old boy, bone exposed, only infected, big gap, non-unions. You can see from day one injury, and I have put the only 2 rings, see, with telescopic rods, and then gradually I have shifted from one situation to another situation, and this is, I have done the tibialization. You can see the whole fibula was moved to the tibia, and this is 1.5 years follow-up. You see, young chap. You can help only with the help of Ilizarov. So this is destruction osteogenesis, infective gap non-union of the femur. I always keep the records, and I have the publications of all the cases. So 65 years old man, infected non-union tibia. Look at this, same case. You can see here, and this is another case, big gap non-union. Look at this, same thing, same case, lower tibia. This is fidelity by Ilizarov technique, again published by Medcrave. And this is 9 years old boy, post-traumatic aseptic deformity, right tibia and fibula. Look at this, the serpentine deformity, just like a snake. And what I have done, fibula transported 3 times. I have lengthened after 1 year follow-up, and this is after 2 years follow-up. From that situation to this situation, see, whole fibula is transported, and it is massive bone now. Now patient is happy. From that situation to this situation, you can do with Ilizarov technique. Again, this is published in American Medcrave Journal. And the biological and mechanical method, biology is the king, weight bearing is easily possible, minimally invasive surgery, feasible in the presence of escarified tissues and the presence of infection. There is no need of free or local flap, no need of graft from iliac crest, so no donor site morbidity. Demerits, dear friends, I don't say any demerits. Only greater learning curve is a demerits. Because you should have to learn from day one to till your death. That is limitless in Ilizarov surgery. That is the demerits. A well-planned step-by-step surgery, Ilizarov technique, you can cover infected non-union of the femur and tibia. This is an excellent method in challenging cases that I showed you all the cases. Excellent results cannot be achieved with conventional methods, but can be easily achieved with Ilizarov technique within 1 to 2 years. And this is, I would like to show you something here, non-knowns. There are non-knowns that you know. There are things we know. There are known unknowns. That is to say, we know there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know. The unknown unknowns I showed you. And this is by Ilizarov. I love to show this one. AD, deformed, dysvascular, dysplastic, destroyed, dislocated, derotation, deficient, and discrepancy. And how you can get peace. The peace means perfect endeavor around the countries of the earth by helping these poor people of the third world country with infected big non-union. You can help a lot to these patients. And see, dear friends, with Ilizarov fixated in the femur, this is, you must have this kind of cut, otherwise he could not put Ilizarov. Space, recess, you can see here. And this is, you see, patient doing exercise with special cut with recess. Ilizarov fixated in the thigh, a special cut with recess. You always advise your patient to go for exercises. So, See, my all patients are doing exercises when they are getting treatment by Ilizarov technique. And my physiotherapist always supervise the patients so that they can go for exercises. And this is, you see, I tell my patients, those who have Ilizarov in the femur, sometimes I see the people's utter this one, like parrot. Ilizarov is cumbersome in the femur. How they say? If you put the Ilizarov apparatus in the proper way, it cannot be cumbersome. So doing exercise in my center, which is the ladder, I advise them to go for fundamental principle of Ilizarov methodology is load and motion. This is the beauty of Ilizarov. And dear friends, you can see with apparatus, patient can walk without the support. This is I'm showing you in the femur. See how they are walking. If you properly fix the Ilizarov apparatus, the patient will not tell you anything. The tightness of the wires, fixation of the nuts and bolts, proper dressings, and follow up with the nuts and bolts all the time. And this is very important. The man who made it possible, this is in graveyard of Ilizarov. That is the written in the graveyard of Ilizarov, great scientist, talented doctor, gifted innovator, creator of the apparatus and the method of the transosseous osteosynthesis, academician, Russian Academy of Medical Sciences, Professor Gabriel Abramovich Ilizarov. And the Ilizarov method is not hard to learn, but it does take proper knowledge, effort, devotion, patience, practice, and intelligent meticulous follow-up. If you really want to do justice to your patients, you should opt for it. And I always love to tell these three categories of things, that is the easy, difficult, impossible. And I like to deal with the impossible cases. These are the animals so that they are doing research work in Kurgan Center. Destruction, how destruction, angiogenesis, tissuegenesis, histogenesis occurring. And this is my center's Ilizarov patients. They are getting treatment properly. In pandemic, even that is difficult. So we try our best to go for treatment with the Ilizarov with the difficult cases. And this is the carry home message. I always love to show this one because I have evidence, I have a science, and of course the surgical skill of the surgeon. It is not very hard to learn this technique, but we need to learn the biology, and Ilizarov is cost-effective technique, and we can do it in our country, in Bangladesh. So these are my publication books. This is Professor Shamsuddin with other Kurgan fellows, Professor Shivsov, Professor Novikov, Borjunov, and Klushin. In the right side, to my left, Professor Klushin, he is the only one man who is very much well known for infection control osteomyelitis in the world by Ilizarov technique. So these are the cases, my friends, my colleagues, my teacher, and here we are in our place in Bangladesh with Ilizarov fellows, those who visited my center and my place, garden in 30 kilometers from here, that is in Gazipur. And what I have learned, the discipline, the way of thinking, the rigorous approach, truthfulness, sincerity, devotion, and dedication, all this from the basis of my academic career. Thank you so much, dear friend. Thank you again.
Thank you very much, sir. Thank you for magnificent presentation, and it's like a beautiful movie, as I told before. Then 35 minutes gone, we just can't think about it. It was excellent. It was excellent, and we know many things about gap nonunion, how we can treat the gap nonunion, and we can manage this type of difficult case by Ilizarov. Thank you very much, sir, for giving us instructions, for showing us beautiful cases that you correct. for the last 20 years for us, for the junior fellows. So, do you use vac therapy in initial stage of open fracture along with Ilizarov?
Yes, me.
I want a question to Professor Bari, sir.
Yes. Can you hear me?
Yes, sir. We can hear you. Can you hear me, sir? I want to ask you a question, hello, sir.
What is the question?
So, do you use vac?
VAC, yes. Now, recently, I'm telling you, at the same time, if you use VAC, I'm using VAC also, and VAC, it consumes your time, it's very good. And there is one dressing, Acticoat dressing. I use Acticoat and VAC at the same time. It gives you very good results simultaneously with the Ilizarov. In not all the cases, in big cases, I could not show you, but I am using. Okay?
Something tibialization, tibialization of fibula. Sir, could you tell us something about tibialization?
Yes.
Within 3 minutes.
Tibialization, if you reach gap more than 10 centimeter, it is ideally you should have to go for tibialization. It is not a difficult operation. Very easy operation. Only you should have to sincere and meticulous approach with this technique. You can go from proximal part of the fibula, you can transport it. Even in the trauma cases, emergency trauma, very big gap tibia. Same CD you can do if you have infrastructure of the Ilizarov infrastructure, everything. Or you can go for gradually by waiting 2, 7, 3, 4, 5, 6, 7 days, 8 days. You can easily transport and you can fix it with Ilizarov wires, even in the infection situation. So nothing to be worried about that tibialization. And within a few weeks or few months, you will get a very good result, good outcome. And at the same time, when you are putting the fibula, transporting the fibula, you should have to tell your patient to go for weight bearing. And it will heal within a very short time. And tibialization is a very good operation, considering the situation of the gap of the tibia. Okay?
We can do it in single sitting.
Sorry?
We can make osteotomy in the upper and lower part of the fibula. Then we can transport the fibula towards the tibia.
Yes.
We can do it gradually, and we can do
it. You can do it in proximally, you can do it in the distally. And you can do it only in the proximally. You don't sometimes, depending upon your case, you don't need to go distally. You can proximally, you do a corticotomy, osteotomy of the fibula, and gradually you can transport. You'll see there is a S-shaped bone callus formation, which will support the neck of the lower part of the upper part of the tibia. And you can put the distal part, proximal, you will keep there. Distal part you can put inside the proximal part of the tibia, and you can fix it with multiple K-wires, multiple olive wires, and you should have to have a very good stable fixation. Otherwise, you will not get consolidation or callus formation. Okay.
After that, you need to do corticotomy part of the
proximal part of the fibula and distal part of the fibula you can do also. I cannot. Yes.
Can you hear me now, sir? Hear me, sir?
You can hear me now?
Yes, sir. Yes, sir.
Can you hear me?
Yes, sir. We can hear you, sir.
Okay.
May I ask a question, sir?
Yeah, please.
Sir, two questions, sir. Do you apply guide wire in all of the long bone transport, even if the soft tissue coverage is not there? This is the first question, sir.
What? Again, please repeat.
Sir, do you apply guide wire in all your long bone transport cases, even if the soft tissue coverage is not there?
Do you apply what?
Guide wire, sir. Guide wire, sir.
Guide wire, yes. I put the all as guide wire.
In all the cases.
All the cases.
Even if the soft tissue coverage, all of the cases, sir.
Even there is no soft tissue coverage, I put the guide wire so that it cannot deviate your proximal part. If you don't put guide wire, it will deviate. Later on, you should have to. Don't think about the guide wire means K wire, 1.8 or 2 mm guide wire you can put. It doesn't create any infection, nothing, because Ilizarov, you have done corticotomy. And corticotomy you are transporting. To eliminate infection, vascularization of the osteomyelitic center is increased by the biological stimulation of corticotomy. And that helps you. And wires. No pins. I don't use pins in the tibia.
Very important question, because I've done in one case without guide wire and I could see a translation and I had to fit.
Yes. Translation. Later on, you should have to do correction.
Correction also, sir. My second question is, sir, do you have seen in any of your cases at the point of corticotomy, is there a sign of infection, sir?
Yes, sometimes you'll get at the sign of. That's why precaution is very important. You should take proper precaution. And sometimes you'll try to follow the very minimum. Don't open up. Don't elevate the periosteum.
Right, sir.
So I do always try to follow strictly the Kurgan method by Ilizarov. They don't open never. Just a small incision, 10 mm. I have a serrated corticotome. Serrated. I don't use pointed. Right. Serrated means serrated. There is marking in the corticotome, and whenever you are putting that on, that doesn't slip. That doesn't slip. Just you.
Sir.
Just you this like this. Put the serrated corticotome after giving after making an incision, small incision. Then put the corticotome. Then with your hand, you just press. Cut the corticotome with the serrated osteotome, okay? Then rotate it 90 degrees. Then gradually, you gently hit. You will be able to understand. This is one method. Another, you can take the twist drill bit. You can make some drill hole from medial to lateral side, lateral to medial side. Then, or if you don't have drill bit, you can use 2 mm K wire just to weaken the bone. Then you can go for osteotomy. You can go for corticotome. Sometimes we are doing corticotome, but we are getting osteotomy, So you should have to be very gentle. You should have to be very, meticulous to get a good corticotome so that you cannot hamper the vessels inside the medullary cavity. And that is very important. That's why corticotomy means low energy osteotomy with the preservation of periosteum, endosteum, and the bone marrow, 3 things. And it will give a very good circulation in the whole limb. So putting the guide wire, I have done a lot of cases and I have shown you this is the evidence. Don't need to. Somebody will tell you if you put the guide wire, you're inviting the infection. No.
Right.
And in Kurgan Center, in open cases, they are using guide wire with hydroxyapatite. That is costly. For my patient, I cannot do that. Right. Hydroxyapatite, they are using with K wires. But in my country, this is costly, I wanted to bring some from there, but it was not possible. This is fact.
Thank you, sir. Thanks a lot, sir.
Thank you. Thank you very much, sir, for your nice discussion. Sir, one last question from my side. That is, in case of fibular upper part of osteotomy, what will be the safe site to prevent the common peroneal nerve injuries? Exactly. This is very important. You should have to know the course of the common peroneal nerve. Just below the, don't go for below the neck, 1 centimeter, 2 centimeter. You just do a osteotomy.
make a drill hole with the K-wire. Then you can weaken the bone, then do osteotomy. Just gradually you pull, and this one like will be H-shaped, proximal and distal part of the corticotomy part. This will be H-shaped, and put the distal part through the tibia, through the tibia. That is very good operation and good outcome, good result. Okay.
Thank you very much, sir. Thank you for your nice presentation, and thank you, Dr. Samsul Sudha, sir, for your great participation with us. And I
Thank
would like
you.
to thank Raj TV for helping us to arrange this type of academic program. And definitely, I would like to thank Renato Pharmaceuticals Limited for sponsoring our program. Dear viewers,
Thank you.
hope we will see you
Today
in the
everything
next
was
Friday.
okay. No disturbance.
Yeah, yeah.
Okay. Thank
And
you very much.
I would like to request Professor Mafakarul Bari sir to say something towards our audience.
What is our aim? Our aim, audience means our young orthopedic surgeons. I always tell them try to learn basic Ilizarov. Basic Ilizarov. Whenever you are putting the Ilizarov, try to use the rubber stopper, proper dressing. In Kurgan, they do so nicely dressing, fantastic. Cover whole the wires so that the patient, even the relatives and the patient cannot see the putting of the wires. If you see from the outside, you will not be able to understand the ring that side, but where is the wires you don't see. This is number one. Just number two, cover of the whole apparatus. As soon as the patient comes to my place, I'm going to do the operation tomorrow. I give the cover, patient. Not I myself. I have one recruited boy. He's doing with that cover and nuts and bolts. That is the wrench spanner. I give the patient in one book how to lead a life with Ilizarov apparatus, written in Bengali and sometimes English, so that the illiterate person can understand easily. And there are pictures in the hands, in the tibia, the femur, how to rotate, how to live your life. Then I ask the questions to the patient. Have you gone through this? Okay, sir. I don't know how to read. Then his relative, he or she reads and tell the patient what is written in the book. I give the book, one box wrench, one spanner, and one cover, so that people can understand. Because you should have to live with it is just like a wife, you know, long time, 6 months, 8 months, 5 months. Not that today you have done and tomorrow no. That's why you should have to love the apparatus. I tell the patient counseling is very important. Before doing surgery, I counsel the patient properly. It will happen like this. It will happen. When I was young, I told the patient everything will be okay, no problem. Now I tell the patient this will happen, but outcome will be very good. You should have to tolerate. You should have to follow. You should have to be meticulous. I tell the patient. This is my advice. For the young surgeons, I tell you, please, you learn Ilizarov. You can solve lot of problems in the trauma and orthopedics. Why I'm telling this? Because I have seen what they are doing in Kurgan. Unbelievable, unbelievable. And in my country, we are doing lot of cases. Yes, we have failures. We have failures. We are not 100% correct. We have failures. Failures again you can correct. I learn from my mistakes, from a junior mistakes, from a senior mistakes. I learn always from the mistakes. And we can do that. So this is my message to the young doctors, to the orthopedic surgeon. Please learn Ilizarov, basic Ilizarov. Then you can advance, you can solve a lot of problems in your life. And that is Ilizarov. I told learning Ilizarov just like learning a language. Still I'm learning. Every day new case, new patient, new case, new lot of non-unions, outcomes different going on with one patient to another patient. This is, you'll see in your life also. Thank you very much for giving me,
Thank you.
Raj TV. Thank you very much all the time, giving us the opportunity to tell for the young orthopedic surgeons so that they can learn, they can serve the nation.
Thank you very much, sir. Thank you very much for
Thank
your
you.
valuable speech. Dear viewers, don't forget, Professor Bari sir said, Elizarov is just like your wife. With the help of your wife, you can face challenges. And just like with the help of Elizarov, you can overcome all the challenges. Hope we will see
Thank
you
you.
in the next Friday. Till then, I'm Dr. Mohammed Tanvir Ashraf saying bye-bye to all of you.
Bye-bye.
Bye-bye.
Shamsulullah, bye-bye. Okay.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.